Thank you for joining us. We've reached the 1 o'clock mark. To get started, we want to thank you for joining us for our Spread Facts, Not Fear, a scientific look at COVID-19 webinar. We will begin here shortly with Representative Daniels.
Good afternoon, everyone. Thank you for tuning in to this week's webinar on Spreading Facts, Not Fear, a scientific look at COVID-19. And thank you to those individuals that are viewing via Facebook. We hope that we know that this information that will be shared today will help you better understand a number of the things that are going on with COVID-19, and feel free to ask questions using the chat, as well as posting your questions and comment in the comment section as well, and so that you're able to get your questions answered during this particular session. I'd first like to thank both of our panelists, Dr. Vickers and Dr. Neil Lamb, for participating today. But first I will introduce Dr. Vickers. He will begin the presentation. Dr. Vickers is the Vice President and Dean of the College of Medicine at UAB. He is well known throughout the country for his work, and especially well known throughout the state of Alabama. And so it's certainly an honor to have you today, Dr. Vickers, and the floor is yours.
So thank you, Representative McDaniel. We appreciate the opportunity to share and at least give some sense of where we are. I think it is remarkable to think back December 31st, where the first case of this virus was described in Wuhan, China, and Hubei province. And that time period was one where no one knew for sure what it was, but what was reported to the WHO was a pneumonia of unknown etiology. So it's a pneumonia that they didn't know what the infectious source was or where it came from. And then you fast forward to soon thereafter, in early January, was the first death in China, the first case in the United States that we at least know for now, and it may not stand in the future as we do more forensics on people who died during this time period, was January 19th. A gentleman who was returning from seeing his family in Wuhan, China, arrived in Seattle with a fever and a significant cough and shortness of breath. And that became the first index case in the United States. Later in February, early March, we had our first community-acquired case. February 6th, now we believe we had our first death due to coronavirus. And then by the near end to mid-March, we had the WHO to go from warnings, using the term epidemic to the term of global pandemic by the mid to end of March. We then found ourselves going from a limited number of the cases where we're clearly well over 2.5 million cases in the world. We are very much still growing, and we're well over, we're going to approach 200,000 deaths. America was behind for a long time as we began following Italy, China, and South Korea. And in particularly, we're now surpassed them at nearly 843,000 cases. And we certainly most likely will have over 1 million by the 1st of May. And New York, as the state and city alone, have more cases than any other country besides the United States. So that speaks to the number and vast infectivity of this virus.
Issue.
I know, but that just makes it more difficult for me to try to refund your card and all that. So I can look at the
those global numbers where in the United States, we're clearly well over 800,000, nearly over 40,000 deaths. We are facing a disease of a magnitude we haven't seen since the early 1900s. I would say the challenge of the virus is that it has a tremendously high infectivity. First, starting out, infections ratios of 1 to 8 describes the measles virus. And so one person gets measles, typically 8 in a setting will pick it up pretty easily. This virus had something close to like 1 to 4 to 1 to 5. And that's significant. The influenza or cold is more like a 1 to 3 ratio. So the virus is highly infective. Its area of attack is troublesome. When you get a cold, it's typically, body aches and upper respiratory, that is the back of your throat, your upper airway, that give you some symptoms, along with the sense of being body aches and fever from the viremia, from the virus in your bloodstream. This virus uniquely attacks the lower epithelial airway cells. And in attacking those cells, it immediately creates a dry cough, not a cough that has production, because it's fairly low in your chest. In addition, because even early on, if you don't require a hospital admission, the virus creates hypoxia, and that is you're short of breath. You can't get enough oxygen. So what people describe are their basic symptoms. They have a dry cough. They can't get their breath. Uniquely because of the cytokines, that are the factors that are released in your body, you get a fairly persistent high fever. And people speak of that sometimes just occurring at nighttime, almost like on a clock. So you get a fever, you get a dry cough, you get fatigue, and you get uniquely short of breath because you can't breathe. And 80% of the people will get better from those symptoms and move on. There are about 15% of those people who will require a need to go to the hospital. So 15 out of 100 typically will need to go to the hospital. And their course for many of them is just supportive with oxygen and nutrition. But there are 5% of them that will have a significant crash. And it typically is like falling off a cliff. They'll go from just difficulty, being short of breath, to a point where they can't breathe, largely because the damage to their lungs is so significant. And as I mentioned early on, the damage, whereas once you get an influenza or a flu, it's uncommon if someone took a chest x-ray that you'd have any damage to your lungs. In this virus, early on, if we took x-rays or CT scans of your lung, you will early on almost certainly have some clear damage to your lung because the virus infects so low in the lung. So with that said, those people who get into the intensive care unit have a drastic different course. They have huge difficulties in getting them oxygen. Their breathing tubes often have to be changed every 5 to 7 days because the damage that the virus creates so much debris that the breathing tubes can't get air through it. It sloughs off all of the lung tissue below. Then it leads to kidney failure. It has shown increased strokes, and it has sometimes cardiac arrhythmias as well. So it creates a tremendous hit because of the cytokines, if you would, the factors that are released because of the tissue damage and the body trying to heal it. And so you have a death rate that's significantly higher than influenza, than the flu. And we see anywhere from 5 to 10% of the infected population die. And if the numbers were only about 100 people, that wouldn't be many. But these numbers, as you know, are massive. So 2 million people, nearly 200,000 deaths. So those numbers are really significant, and they affect our loved ones, and we see them affect our country. The final thing I'll say is that in Alabama, I think we have done a nice job. We're not perfect, but we're certainly not an outlier. One of the areas that's very similar to us that gives you pause is Louisiana. We have 4.8 million people. Louisiana has 4.6 million people. We have about 5,000 cases, or a little over 5,000 cases, maybe 5,600. Louisiana has right at 25,000 cases. And that just tells you how significant this is. We have 198 deaths. Louisiana has over 1,000 deaths. And so they've been hit massively hard, largely as people think about Mardi Gras and a St. Patrick's Day parade that truly promoted the spread of the virus, and it's wreaked havoc on a very challenged healthcare system as it was for taking care of the population. So there are states like that that are suffering. New York, you've seen and heard about having massive numbers of patients and still dealing with them and looking at death rates. So in our area, we typically don't see a high number of death rate per 100,000, but the areas related to New York and related to Louisiana have significantly higher death rates per 100,000. In fact, if you were to look at Alabama, we are often in the lower numbers, at best the teens, and not very high at all. We have about a death rate for the whole state of only 4 per 100,000. If you look at Louisiana as another example, Louisiana's death rate as a state is 30 per 100,000, and there are certain counties over 100 deaths per 100,000 because of the virus being so severe. The final point is that you've heard, and I think it's important, the virus has truly uncovered some flaws that relate to our own health system and the status of our citizens. One of the pre-existing problems we had before the virus ever came was significant health disparities. And those disparities largely affected African-American populations across the country by having heart disease, diabetes, hypertension, obesity, as well as renal disease disproportionately higher than their white counterparts. Multiple factors created, and I won't go through all the details of why those disparities exist, but what they have shown is that as the virus has now put another level of stress on our system and on our populations, it has shown that it has really created a high level of lethality among our African-American population. Whereas in most of our states, like Alabama, a quarter of the citizens are African-American. There have been times where certainly greater than 50% of the deaths have been due to African-Americans. Early on in New Orleans, 33% of the population African-American. There was a time in the accounting of numbers that 70% of the deaths were due to African-Americans. It's still 55%, so it's still significant. In Alabama now is about 46 or 47%, still disproportionately higher in our population. That holds true whether you look in Maryland, Detroit, Chicago, or New York. we are disproportionately suffering from the virus because of our pre-existing conditions and because we were exposed more often because we're in those essential service jobs. The people who do the house cleaning, the people who work in the grocery stores, who work in the cafeterias in the hospital, they can't do their job from home. And so many of the essential services are our people who need to be there, and they are exposed, and they've often had limited testing. So the numbers are pronounced for African Americans across the country, and it's demonstrated to all who can see, who have thought that these were not significant issues. They've brought to the forefront that this is a major issue that has been really taken advantage of by the virus and brought to the forefront due to a number of things, including access to healthcare. I'll stop with that.
Thank you, Dr. Vickers, for sharing with us. We will now move to our second panelist. Dr. Neil Lamb is on the line, and he's the VP of Educational Outreach at HudsonAlpha Institute for Biotechnology.
Good afternoon, everybody. I am joining the call from my home office, probably like many of you, which is also known as our guest bedroom. The internet gremlins seem to be especially active today, so we're going to cross our fingers that we make it through the conversation. I'd like to start by thanking Dean Vickers. He's done such a fantastic job of giving us a background, giving you a clinical understanding of where we are and the challenges that we face with COVID. There is a flood of information coming at us. Every hour there are new stories coming from around the world, coming from scientists and clinicians, and it is incredibly challenging to try to keep up with all that information. And the virus isn't the only thing that spreads rapidly in the middle of an epidemic. Misinformation and confusion are its constant traveling companions. And that means it's really critically important to provide the right information. America and Alabama's ability to minimize the spread of the virus in the weeks and months ahead really depends on the public's willingness to change some of our behaviors and not to become complacent about things like social distancing and proper hygiene. And this isn't the time to say we've won because we've crossed the peak and go back to a pre-COVID mindset. So people need really trusted sources of information delivered without slant, using everyday common sense language. Lots of groups across our state are doing just that. Every time Dean Vickers and his colleagues they do an interview or they post online or a Zoom call like this, they are doing that. We're trying to do the exact same thing at HudsonAlpha and making understandable science that everybody can identify with, that they can see as a trusted source. I'm the leader of our education outreach team at HudsonAlpha, and so we've built a series of short 4 to 6 minute videos under the heading of shareable science that provide basic information about COVID-19, about the virus that causes the disease, about symptoms, the difference between molecular tests and antibody tests, antiviral treatments, what's coming with a vaccine. We answer viewer questions like, will the virus disappear in the summer heat of Alabama? And can you get infected from a mosquito? A whole set of key content, science worth sharing for people to be able to understand. We create and post a couple of videos every week. Most of these right now are from the guest bedroom here in my house, and you can see the whiteboards behind me. It's usually just me and a whiteboard walking through some science in simple, straightforward language. You can find them on the website by going to hudsonalpha.org/shareable-science. So hudsonalpha.org/shareable-science, or you can just go to your favorite search engine and type in COVID-19 shareable science, and it'll pull up. The videos have been shared widely across Alabama, really across the country, as many of our middle and high school teachers in the state have looked for resources to share with their students in health and their students in science. They're using a lot of these videos, they're incorporating them into their lessons. A lot of the public is looking at the videos and sharing them through Facebook and Twitter and with their family and their friends. So I would encourage you and your friends and colleagues to take a look at that. There's a way for individuals to send in questions if they'd like more details, more information, they can do that. And we also have created a PDF of 22 common questions that people ask us about COVID-19 and about the coronavirus. That'll be shared with all of you on this call. The PDF has links to other websites for other resources and also points you to the specific videos that we've created that actually are relevant for each of those areas of disease spread and symptoms and treatment and testing and each of those pieces. So I hope you find that those are useful. It is so important to help people find access to information that doesn't have a slant to it, that isn't full of myths like if you get coronavirus, you can sweat it out in a sauna, or if you point a hairdryer down your throat, you're going to heat the virus up and kill it. That is circulating every day in people's inboxes and on their social media feeds, and we're trying to counter that with common sense, trusted information. So at that point, I'll stop because I think the goal is for us to provide lots of time for folks to ask questions. I'll just say thanks to the Democratic Caucus for allowing me to join Dean Vickers on this call and to share this information with you.
Thank you both so much. And yes, for all the viewers, you can type in your questions to the chat box or the Q&A, and we're going to start by reading them from there. And so our first question says, do you believe that the rate of transmission, or RT, is a good measure of a downward trajectory? And either of our panelists can jump in.
I think that there are a number of factors that relate to that sort of a good measure of a downward trajectory. I think the rate of transmission is limited by the fact if you use the number of tests that you do and the number of positive cases that you detect. It's a reasonable way to look at it, but it's limited by the fact that you haven't tested broadly in the population. So you just don't know how accurate it is, except some of an isolated measure of those who felt or you felt were at risk for getting the virus, since we test mostly only those people who we think have symptoms or who had exposure. There are two other numbers that we can use that are truly measurable, and we know them to be true, but they may not represent the entire population either. So if you look at hospital admissions and you look at discharges, and if you look at hospital deaths, all have their limitations and skewed by factors, but they are pretty reproducible and measurable. They also can be surrogates to say that there is a downward trend as those numbers go down or plateau or stop rising. Neil, your thoughts?
Yeah, I would agree with you, Selwyn. I think that we right now are not doing enough testing to really be able to get a good handle on that. We've got to test much more broadly. And I think some of the antibody tests, the serology tests, may give us some additional insight into that as well. We just aren't at that point yet.
And going along with that, the next question was, what type of testing do you recommend as a priority? And is there a plan to expand it in the state?
I'll let you go first, Neil. I won't precede everything.
Fair enough, but I'll note that the gentleman who has MD after his name should be the one that answers all clinical questions first.
All right.
But so I think there are two different broad categories of tests right now. There are the molecular tests that are looking for the genetic material from the virus. These can help you detect if you are in the middle of an active infection, although there's some window of time where you may have been exposed and they were infected, but you're not making enough virus to be detected. Those are the tests that we have traditionally been working with over the last several weeks. Then there are what are called serological or antibody tests. These measure if your body has generated an immune response to the virus. They do not work for the early stage of infection because these antibodies don't appear until generally at least 7 days after you've developed symptoms. But these are great at detecting individuals that might be asymptomatic, individuals that may have had the infection and have recovered. So I think we're going to need to see both of these tests really take their place as we think about who's been infected, who potentially can come back to work. In each case, we've got to have real confidence that they're accurate, that they measure what they need to be measuring, and that we have enough of them, not simply to be testing the most likely candidates.
Yeah, I couldn't agree more with Neil. I think we need both. I would say that if I were to preferentially at this time say what we need more of, it's more of the molecular test, because we still can't test broadly, and we will need to test broadly as we try to reopen. We'll need to have people to have significant access to testing as we expose more people and as we get those individuals who are either symptomatic or have some principle to test those who may have some evidence, who may be asymptomatic but still have some risk of carrying the virus. So we don't have enough. I think the state health lab can do probably 350 a day. It's limited by reagents more than the issue of their ability. There are units like HudsonAlpha and us, who we can also do significant numbers and maybe even more than that. But the limitations are still, can you get enough reagents to do it? And that's unfortunate. I think Neil's right about the serology. They are the factors that, number one, there are about 100 different kits on the market, and there is a lot of error, driven by the fact that there are probably 6 to 8 coronaviruses that you were infected with last year, and that give you the common cold. And so many of these tests can pick up not COVID-19, but another coronavirus that simply gave you the flu and not necessarily give you the true sense that you have antibodies developed to COVID-19. But they can tell you, as Neil said, after a week or two, whether you've developed some level of immunity and antibodies. And then secondly, the only other challenge is that all the early studies sort of indicate that if you were to test 100 people, 5 of them will probably be serologically positive. And so you got to ask the question, yes, it tells you what to do with the 5 who are positive. They can go back and have low risk of infection. But what do you do with the other 95? So it's as we get greater numbers of our community that have some level of immunity or antibody detection, it can provide a greater sense that the community is protected. But right now, the number of prevalence of those who have antibodies is still very small. So you'll have to do it on large scale to know what numbers you can get, and you'll have to decide what you do for those who actually still are negative for antibodies.
Thank you. Our next question, is a person who is COVID-19 but asymptomatic still only contagious for 14 days, or is there a longer period of contagion for an asymptomatic person?
So what we know, it still evolves the fact that as we learn about the disease, we clearly believe if somebody has risk of exposure or had the virus, they may, in fact, if they're not symptomatic, be free of the virus after 14 days if you've been exposed. And what we use right now as a part of the CDC guidelines, that if you've been diagnosed test positive, if you have symptoms, we would ask you to go 7 days and then an additional 3 days after your symptoms stop. Now that's the assumption that 13 days or 14 days or whatever number that ends at, you might not have virus to shed. But the course of the illness can go several weeks. People can be sick for a long time and shedding virus for a long period of time who are actually sick. asymptomatic individuals, there's a recent paper in one of our well-known journals, Nature Medicine, that looked at about 90 people who had the virus and about 70 or 80 people who got infected from them. And what they clearly showed is that, number one, the heightened period of where they shed the most virus was clearly before they had any symptoms. And it was the period that they were had the most ability to cause infection without symptoms. So it does bring to bear and that number was in 44% of those patients, they found that. That's very frightening to think that there are people around who have no symptoms and they potentially are highly infectious and we just don't know who they are. And those numbers, people have talked about anywhere from 20 to 40%, probably on the 20% area number where that many people may exist who are in that condition.
And I think that's one of the reasons why you see the CDC recommendation about face coverings, because cloth face coverings, yes, they'll give me some protection against potentially getting the virus from somewhere else. Here's the face covering, the mask that my mom's made for me. But more importantly, they help stop any or a significant number of particles that I may be shedding if I am asymptomatic and infectious. So wearing these face coverings out in public is as important to help stop the spread from other people as it is for any protection it might give me.
And I would say of what's been said, what Neil said is most important, because as we try to reopen, he is so right to say, don't confuse why the masks are going to be asked for everybody to wear. It's not to protect you. It's to actually protect everybody, because you don't know whether you have the virus or not. And if you do, you want to make sure you don't spread it broadly and also have others do the same.
Our next question, when do you think post-secondary education institutions will be able to safely return? And what measures can be taken to lessen the risk of transmission in the classroom?
So we're in the UA system now. That is at UAH, UAB, and UA in Tuscaloosa are now working through the scenarios of what that would look like. I would say that the contingencies are based on two extremes, I would say. One extreme is our abilities to test and our abilities to do serology and treat haven't changed by August 1st, right? We're in the same capacity. We can't test much more. We don't have a drug that works, and our serologies aren't that accurate and aren't prevalently used. Then the contingency one is that you're probably online again in the fall. And that's what one university, Boston University, has already done that. We believe and hope that we won't be in that position, that we'll be somewhere in between. The panacea is that we can test 1 million people in a day in our area, or we can test hundreds of thousands in a day in Alabama, or send that to get tested in those numbers, such that for every student or highly selected number of students and broadly systemic testing could occur, so schools would have really a significant understanding of who was positive and know about every student who came in and every faculty member and every worker. So, but that's massive testing numbers. We have seen that just 2 days ago, the FDA approved a home kit for $119. You can get it and mail it in, and you'll get a result back in 48 hours. So you can see the evolution that maybe as a part of a matriculation fee, some schools may ask kids to do a test. HudsonAlpha is working with other national leaders to develop high testing capacity, where kids may be sent a test kit and they mail it back into them to know what their status is. So what will occur is some increased testing is going to happen. Number two, there may be these models where everything's online, or the next phase, it's a hybrid model, and that is the class is taught 5 days a week, and on Monday and Wednesday and Friday, one group comes in person and the other group does online, so you can keep the density down. So you don't have 300 people in one room sitting right next to each other. You'll have to have some significant testing and standards around how do you put people in dorms. Again, it's going to be driven by what our capacity is to do it. And no one's broached the whole subject of what do you do with athletic events, because that too is going to be really built on whether serology gives us enough information to act on or whether we have enough tests. And when you go to the ticket gate, you not only have your ticket scanned from your phone, you have your test results scanned from your phone to determine whether you can enter. Those are just the ideas, and those are the things that might have to be considered, but all driven by where we are in this time, maybe midsummer, of what our capacity is. Any ideas, Neil, that you might have?
I think, Selwyn, you've done a great job of saying there's a broad range of unknowns of what we're dealing with. And I think it's so exemplary of what the next several months for our society are going to look like. This concept of going back to normal, it is not going to look like it did in January. And we're going to have to acknowledge that we're going to be in a dance for several months, a dance with the virus. How can we behave in ways that minimize its spread, but still allow us to interact and engage? And at times we're going to have more isolation, and at times we're going to have more freedom. And we're going to be in that dance until we have meaningful treatment and vaccine. It's just the reality of what the next several months look like for us.
Yeah, and kids, I would suspect somewhere in between those models, people will be asked to wear a mask on campus. They will be asked to follow all of these rules. And Neil's right, it's a new normal. It's not returning back to the normal that we think about until we get a vaccine. And a vaccine's probably a year away. Even when we get it and think it works, you got to make 1 billion doses because the whole world will need it.
Thank you. Our next question, it says, you've mentioned the inequities in the healthcare, and our healthcare system is under great stress already. Rural hospitals have been closing. Is there a plan or any advice for the healthcare in rural areas to be sustained during this pandemic?
You know, I think the first thing that Neil and I have said that's so important to every area of our state, but I think our most vulnerable community, which include rural and often urban communities that have limited access to healthcare, it's going to be important that we prioritize testing them, because in this disease, if we don't test our most vulnerable, we are all at risk. You can't say in my groups, we are all tested and we're fine. But the reality, if anybody in your society hasn't been tested, they're at risk to have this virus spread and recur again. And we can't treat it like, unfortunately, like we've treated health disparities to some degree by saying that's somebody else's problem. The reality is this virus is everybody's problem. It's all of our problems. And it has made clear that just people who are managing their disease, it's not that they're non-compliant, they're taking care of their diabetes, they're managing their hypertension, and they're getting their dialysis. If they get infected, they have a much higher chance of dying in spite of them trying to take care of it. So it says that we have to actually, it's a wake-up call about us as a healthcare system and a society approaching it. I don't know that there is any immediacy to do anything about rural hospitals in this setting. I think there are efforts and desires to try to increase testing in those rural areas in order to make sure that we get them access and provide an opportunity for them to actually return to some level of the new normal like we want everybody else to.
I think it's important for our listeners to remember that this virus is an equal opportunity virus. And so there aren't black and white, Auburn and Alabama, California and New York, America and Italy. Everybody is impacted by this. And the decisions that we each individually take will determine what the next several months look like for our community. So we are taking actions for everyone, for the most fragile in our society, for the frontline workers, for the individuals that can't work at home. We have to behave in ways that are responsible and that protect everyone.
Thank you. Our next question says, is there a checklist being developed as a means to determine when the state will open back up of certain targets that have to be met?
Yeah, there are some guidelines given by the White House, and there are a number of them that have been sort of nationally put forward. They relate to seeing a declining number of infections or rate of infections over a 14-day period. People have also talked about, as you mentioned earlier, about admissions in the hospital, deaths and discharges. The rate of infection, people have talked about as well. But the first one is what's put forward. And then secondly, having an increased capacity to test and trace. That is, if we were to look at one of the remarkable countries, South Korea last Friday reported for a day that it's a country of 60 million. So it's bigger than any of our states, but clearly larger than New York in number. But they had only 8 positive cases for the whole country. And they have a remarkable tracing mechanism driven by an app. Once you enter the country, you have to have it. Once a person who has been identified as positive, it's in your region or your area or in your block, you're notified of the place where they work, and you're given a sense, you're given a map where they've traveled and their location in order for you to actually be aware of your environment. And it's worked remarkably well to isolate individuals once they've been tested positive and to limit further exposure. So testing and tracing, and then adequate PPE, adequate enough of the safety equipment, particularly masks, for the broader community to be able to use and not further risk infection because we haven't tested everybody. And social distancing to be maintained and the standards of density that we talked about as principles to go forward. Those are some of the things on a checklist that people will be looking at to be both thoughtful, strategic, and pragmatic as they phase activities to be restarted.
Our next question, with people starting to make more face masks, is there anything we should be cautious of or any guidelines we need to adhere to?
So I think the key, a really important piece about this is the behavior of our face masks. So your face mask is not meant to allow you to get even closer to people. You still need to keep appropriate social distance. You should be wearing your face mask when you are out in public. You are your cloth face covering, and there are all kinds. Some that tie around the back of the head, like mine. Some that have elastic straps. But I think one of the most important pieces is that we don't normally, as a society, wear face masks. So when we first put it on, it feels unusual, and we adjust it and we fiddle with our glasses or the mask. And what we're doing is we're unintentionally touching the front of the mask and then bringing it close to our skin, which is exactly the opposite of what you want. You do not want to be touching your mask once you put it on. So get it adjusted before you step out of the car, before you step into the store. And then when you untie it or take it off, again, don't be putting your fingers all over the front of it. Assume that it is contaminated. Drop it into a paper bag or drop it straight into the washing machine. We have to be smart about how we put our masks on and the way we think about the message that we are sending with those masks on. Selwyn, you probably have more to add to that as well.
I think you have a good point. The only thing I'll mention about the last question, the other checklist item is hospital capacity must be there for ability to take care of any resurge that comes on. Those are the 4 things that are sort of benchmarks. I think Neil's right. He first was right earlier. What's the purpose of the mask? I think bandana, homemade mask, it's to provide a barrier for the risk that you're carrying virus, and you will clearly have a risk of infecting it. There was a study in Seattle, right north of Seattle, where they were in their rising cases, and they hadn't quite got all the social distancing down. A 60-member choir decided to come together and practice for Sunday because they hadn't shut churches down. And in that choir, they sang that for about an hour and a half. 45 out of the 60 got infected. 2 died. And the reality is you can get infected from talking and spreading. And so it really does provide a barrier. These are not surgical masks you're going to use in the hospital. They're not the N95 masks to protect you from getting it, but they are a clear deterrent from the virus being spread broadly for those who are unknowingly carrying it by wearing a barrier.
Next, we have, being that there's not enough testing happening yet in Alabama, do you think we should still be sheltering in place and following the health orders in place right now for longer?
I think certain things have to be done. So as of now, yes, I think we should. I think there has to be a plan for certain things to be done in parallel. I think that the idea of the testing is crucial, and I think we have to set in place the infrastructure and every wherewithal that we can to give high and increased access to testing. The limitation will be, our execution of it will be, can we get enough reagents? And if we can get enough reagents, that can make it happen. I don't know if you have to do that serially as so much as that it needs to be a parallel process that you do, so that you are gradually, as it becomes available, or rapidly as it becomes available, increasing access to testing as broad as you can, as you allow people to get more exposed to higher densities and to more places where they might either shop or do some activity. So I think that you do need to see a decline in the cases. I think once you meet meet the criteria that in place, I think you then need the testing piece will not occur overnight. It's not dependent on the states. It's depending more on a national level. And it won't be automatic. It will need to grow gradually. And so I think it's something that can be done parallel.
And I also think that individuals that are at the highest risk are oldest members of society, individuals that have one of these pre-existing health conditions, diabetes, hypertension, obesity. They need to be the ones that are the last to leave their homes. They need to continue staying at home and ordering groceries online. Once they lift some of these restrictions, we don't all need to suddenly flood into the marketplace. We're going to need to continue to do this with an awareness of the risks that each of us might carry.
Thank you. Our next question is, how effective is the drug hydroxychloroquine against the COVID-19, if at all?
I think Neil was quoted to say this was a game changer. Neil, I'll let you speak about it.
I was actually going to say that the person with the MD should actually answer this question.
But I think we would both agree that there's no doubt we are desperately looking for a drug that works against this virus. But I think Neil knows as well as I, there are so many things we do experimentally that look extremely positive, and they never work in a human. If they did, we would have probably most diseases cured by now. And so the pushback you heard from scientists early on is that the studies that were touted were done very poorly. And so you couldn't, although you wanted to be excited about it, you had to resist because they really couldn't tell you anything. And so what the problems were associated with, the drug does have a role for people who have some diseases related to their immune system, rheumatoid arthritis, lupus. Those people need that drug, and there are people who have suffered because they can't get it. The drug in a test tube shows some activity against this virus, right? In a test tube. And so that does lend to try it, but you got to try it to make sure that it first doesn't make the patient worse. That's the first step. The second piece is then you have to then try it at the next level to see if it makes them better. And then you have to try it at the third level to see if it makes it better than what you're already doing. And those tests weren't done and haven't done. And in the journey to get there, it is clear that the drug can do harm. They've stopped 1 or 2 trials already because people have died of arrhythmias, because the drug can do something called shorten your QT interval. It can make your heartbeat abnormal and lead you to a ventricular fibrillation and arrest. So it's not a panacea. And then secondly, in the early studies, it doesn't seem to be any better than what we use in the support mechanism now for patients. And it's not final yet, but the studies so far don't show or highlight any benefit that gives further gleaming hope that it's making a positive impact.
I think scientists and clinicians are always hopeful that this medicine or that therapy is going to be the silver bullet. But every single one of us has had an experience where the early data pointed us in one direction, and the more we got into it, we realized that that wasn't the case. So we have to let the scientific process do its job, even if that frustratingly means that it is slower than we would all like it to be.
Thank you. Our next question says, what steps has the state taken to update or contact tracing processes? Are we using new software or state-of-the-art methods to do contact tracing? Sorry.
Selwyn, I don't know much about the way we're doing contact tracing. I hope you do.
The state has a method, and we are trying to work with them to get as advanced and sophisticated a method as possible. So there are ideas and there are companies that you've heard about that have tracing mechanisms to begin to put in software. Our hope is that very soon they will have additional capacity. They do contract tracing now. It's pretty labor intensive. It involves getting people, when somebody's identified, to go connect with them, often getting them tested or getting them information about being isolated. You may have heard Governor Cuomo say that Mayor Bloomberg was going to sponsor that for New York City, which is going to be millions of dollars to get it done, and lots of people, thousands of people to go out and contact and connect with people who've been exposed. So there is a tracing capacity in our state. It needs to be more robust, I think, and we are working to try to get the most novel software to be a part of that process.
Thank you. Is there a state plan in place to work with the HUD homeless organizations to ensure that those persons that are street homeless are being treated or have access to masks, gloves, testing, etc.?
I don't know that there's a state plan. There are regional plans to do that. So in Birmingham, there are plans to try to help mitigate that for homeless and provide space for them. There's certainly many places across the country that's done that well. But I think if it is occurring, it's more in the regional areas that may be doing it. And I know Birmingham has a strategy, but I don't know for the rest of the counties or regional areas. And I don't know that the state has a plan.
Next question says, have there been any readmissions due to COVID-19?
Are they asking, is there someone who has gotten better, tested negative, and re-got the virus? Or has someone sent home and eventually come back because they weren't really well? And I would say there's probably certainly been readmissions from individuals who were sent home and bounced back because their lungs just failed them. I don't know the data, but I wouldn't be surprised. I would expect that that would have happened. There are about 100, 110 cases from South Korea, which are a bit perplexing, and we don't know the answer. What they claim is that they've had about that number of people who they've tested positive for coronavirus. They got better, they tested negative, and then they got virus again, and they retested positive. Now, what we don't know is, are they testing live virus or dead virus? I don't know. The test will amplify either one. So it's possible, potentially. I don't think that that's the norm. I think it may be a more of an abnormality than actual a common fact.
I've seen a couple of papers that have actually looked at the level of virus in the nasopharyngeal swabs, the nose swabs, compared to the level of virus in, say, sputum or in blood over time. And it seems that the amount of virus in the nose swab that you can recover from the nose swabs drops, and then it reaches a point where it kind of bounces around a little bit as the person recovers. And sometimes it's below the level of detection, so it would give you a negative result. And then a couple days later, it may bounce back above and give you a positive result. And so some of the possibility may be that these individuals that tested negative were in one of those windows where their amount of virus just happened to be below the level of detection. But it wasn't that they were reinfected, it was just that they had a longer time course with a relapse on the back end.
Absolutely.
Next question says, as discussion turns to a second wave, how ready are our hospitals to handle this, and what precautions should we be taking now to prepare?
You know, I think, and Neil put it best earlier, the distancing, the mask, the washing your hands, those principles need to really be the ones that keep us prepared. I think the risk we have is that as we reopen, we don't carry the same level of intensity and vigilance that we had when we started into this infection. If we go back to thinking that it's normal and we can simply go back without any facial covering, we can start shaking everybody's hand, we can get in crowds, those are the things that will give us a greater risk for a resurge or a rebound infection. So that's what we should do. We should own that to make sure we don't get that back, and accept the fact that the way we're going to live is going to be different for some time until a vaccine is in place. The hospitals are prepared. The models truly overestimated the burden of disease early on in Alabama. The newer models show that we have plenty of excess capacity. And that speaks for almost any part of the state you're in, because in the state of Alabama, there have been only 2 hospitals that have had probably more than 20 patients admitted at any given time. UAB and East Alabama Medical Center. I don't know that anybody else has more than 20 patients in the hospital, and 1 hospital that's been COVID positive. So there is tremendous capacity here if we do get a surge.
I would agree.
All right, our next question says, with the depletion of disinfectants and hand sanitizers, do you recommend a recipe to make your own disinfectant spray to clean surfaces at home and office?
I can jump into this. So fortunately, we're beginning to see more of these disinfectants and antibacterial gel coming back on the market. I would start by saying that plain soap and water is the best way to break up this virus if you're concerned about it on your hands or concerned about it on surfaces. The virus has a really fragile fat-based membrane that soap simply tears apart. That said, if you need to make your own hand sanitizer, there are a number of recipes out there that you can follow. It's pretty straightforward, but the key is, at the end of the day, you need a final alcohol content of more than 60%. And a lot of isopropyl alcohol that you buy, rubbing alcohol that you buy in the grocery store, starts out at a lower percentage, and by the time you dilute it, you're now below 60%. So you've got to be really careful that you're using the right ingredients. And no, you cannot do this with vodka from the shelf. That is not going to get you the level that you want and is a waste of perfectly good vodka. So yes, you can do it. I don't know that we're at a place where we really need to be moving down that pathway.
I agree.
Thank you. We had it says the clarifying needs to happen before we can be sure that some of us are now protected by antibodies and can go back to work.
Can you repeat the question?
Yes. Can you hear me now?
Yes.
Okay, sorry. Can you clarify what needs to happen before we can be sure that some of us are now protected by antibodies and can go back to work?
You know, you go back to the 4 principles that I think that we talked about: PPE, mask, our ability to have some test capacity, which may also mean serology, hospital capacity, and a really evidence that the incidence of the virus or its prevalence in our community is going down. I think that when you talk about go back to work, it's going to depend on what type of work you're actually doing. If you're in a restaurant that has, 100 tables and 100 square feet, that may be a while. If you're, in a area that's high density, where a lot of people are working in a tight area, there probably need to be some modifications to the spacing in order to keep you and your other coworkers safe. So there is no one thing that I can tell you that has to be in place. It really depends on what type of job you do. If you're in a retail business and you have a store and you wear a mask and your customers wear a mask and you limit how many come in, you might have capacity to go back sooner than later. But so it's variable to your job and what the environment will be like, as well as to the principles that you follow or are required to follow to return.
And I would just add that specifically for the antibody issue, I think that the serology tests are going to be really valuable, but the science, we are still trying to get our hands around all of the science. We just released a video today about antibodies for testing, and there's such a range of accuracy among the tests that are out there. We need to give this a little more time before we can clearly say, this is the test that we should be using and this is how we should interpret it.
And are there any current avenues being explored to use phylogenetic methods for tracking and tracing undocumented cases of COVID-19 to deter new infection?
So phylogenetic methods are sequencing through the entire genome of the virus and looking for genetic changes in the code and then comparing that to the sequence of individuals that, the sequence of viruses isolated from other patients. Only a tiny, tiny fraction of all the individuals with COVID-19 actually have the genome of their virus sequenced. But there's a great website called NextStrain, NEXTSTRAIN, and recognizing our time that we're past our hour window, I'll keep this really short. But scientists around the world are using this to track the movement of the virus, where it's coming from, how it's moving from place to place, and the level of mutation that's happening. And fortunately, it's mutating at a very low rate. It seems to be very stable, which bodes really well when we think about vaccines.
All right. We want to thank you for joining us and for all of this invaluable information that you've shared with us today. And I will turn it back over to Representative Daniels to close us out.
Thank you, Katie, and thank you to our staff and the legislators that are present on this particular webinar. Thank you for getting the word out and making certain that we're providing valuable content to our constituents and also those individuals throughout the state of Alabama. I want to also give a special thanks to Dr. Vickers and Dr. Neil Lamb for taking the time out of your busy schedules. I know that you guys are in high demand, and you could be doing any things in other areas and being pulled in different directions. But we want to thank you for taking the time to share this valuable information with our members and also their constituents and our constituents. So we want to thank you for what you do, and we look forward to continuing to provide content for those individuals that are listening on Facebook or watching on Facebook, as well as those that have signed up for the webinar. Thank you.
And one last thing to close us out, there was a question. So this webinar is posted on our Facebook page so that you can review it at a later time. And if you do have any additional questions or anything, you can our email at askahdc@gmail.com. And we have prepared a resource packet with the information that Dr. Lamb has told you that will be disseminated, and we will get it out to all of our viewers here. So thank you for joining us.